Good evening to all our viewers of OrthoTV. A warm welcome to you all. We are here with the 15th episode of the second season of series on controversies and consensus in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with an interesting case presentation followed by a discussion in each subspecialty of orthopedics. This session is being dedicated to the young orthopedic surgeons having interest in each subspecialty of orthopedics with the goal of uniting skill with mastery, where the presentation is being moderated by an expert in that field. This platform is not only aimed at helping the young orthopedic surgeon to present their case and strengthen their communication skills, but also reach to a broader and more diverse audience through our OrthoTV channel, thereby increasing their visibility and exposure. This program is conducted under the chairmanship of Dr. S.S. Mohanty and Secretary Dr. Ashish Phadnis, Dr. Mrinal Sharma, and myself, Dr. Deepak Gautam. Dr. Mohanty is the professor and unit head in the Department of Orthopedics at Surgeries Medical College and KM Hospital, Mumbai. He is an honorary consultant at Jaslok, Nanavati, and Sushrusha Hospital. He is the past president of Bombay Orthopedic Society, an academician and a researcher. Today, we have three brilliant young orthopedic surgeons, one in each field of arthroplasty, arthroscopy, and tumor, with an expert panel including Dr. Sanjeev Kumar, Dr. Sandeep Biraris, and Dr. Bhaskara. Now, I would now like to call upon Dr. Mohanty to introduce our presenter and proceed with the session. Dr. Mohanty, sir, all to you now.
Thank you, Deepak. Good evening, dear friends. Greetings from Mumbai and welcome to the 15th episode of the second session of Controversies and Consensus in Orthopedics. Today, we have three expert presenters and three expert panel in the field of arthroplasty, arthroscopy, and orthopedic oncology. So thank you for joining and thank you for all the presenters as well as moderators for being here for the cause of academics. Without any further delay, let us start the session. Let me share my screen and introduce the first speaker. So first case will be presented on arthroplasty, and we have Dr. M. Kalaivanan, who has finished his MBBS and MS Ortho from KM Hospital, Mumbai. He was a junior resident in orthopedics from KM Hospital from 2013 to 2016, followed by a specialty medical officer for a year from 2016 to 17. Then he completed his fellowship in the arthroplasty in Greece, and at present continuing as a trauma and arthroplasty consultant orthopedic surgeon from 27 until now at Kaveri Hospital, Tiruchirappalli, Tamil Nadu. He specializes in trauma and hip and knee arthroplasty, and he has been a very enthusiastic worker, as you know from his KM days, and he has been, very active in the field of arthroplasty as well. Welcome, Dr. Kalaivanan, and thank you for joining today. Now, to moderate this case, we have Dr. Sanjeev Kumar with us, who is a professor in the orthopedics surgery at King George Medical University, Lucknow. Professor Kumar is a renowned joint replacement and complex trauma surgeon, and he's very well known to the Indian orthopedic surgeons. Thank you, Dr. Sanjeev Kumar, for joining today. Now, I stop sharing the screen and welcome Dr. Kalai to present his case in arthroplasty.
Thank you, sir. Thank you, dear my professor, Professor S.S. Mohanty, sir. So I'm a student. So I was very lucky to present here the case. I'm sharing my screen. Good evening, everyone. So I thank the OrthoTV for giving this opportunity to present in this forum. So today I am going to talk total hip arthroplasty for displaced femoral neck fractures in elderly. So fractured neck of femur is most common in elderly age because of the osteoporotic bone. So results in excessive morbidity if it is not treated properly. So for young patient, osteosynthesis as far as possible should be considered. For displaced fracture, especially Gordon type 3 and 4, especially in elderly patients, the hip replacement is a treatment of choice. so which provides a stable, painless, mobile hip. So as far as literature is concerned, bipolar arthroplasty is a standard surgical treatment. However, the primary total hip replacement is being increasingly used as an accepted modality. But the major concern here after THR is a dislocation, as ranging from 3% to 14% given in the literature. So today, here I am discussing some concepts of surgery, especially the hot hinge approach, that is a modified hot hinge approach. So here, sir, I am audible to everyone?
Yes, yes.
Hello,
Yes,
sir?
yes, you are audible. Yes.
Yeah, you are audible.
Yes, yes. So here, patient was, after spinal anesthesia, patient was in lateral position. So here I am discussing some important concepts of the direct lateral approach, that is a hot hinge approach. So you can see here, the incision was made just to centering the trochanter, get a trochanter for about 10 to 15 centimeter. Initially subcutaneous fat, then the fascia, then you can dissect the gluteus maximus muscle, splitter anteriorly and posteriorly. Then on further deep dissection, you can identify the trochanteric bursa. After incising the bursa, you will encounter the trochanter with the superior attachment of gluteus medius and inferiorly the vastus lateralis. Here, what is modified hot hinge? Modified hot hinge is directly we are splitting the anterior third and posterior two-third of the gluteus medius muscle, directly entering the capsule. So here the important concept here is about the gated trochanter about 5 centimeter above the gated trochanter that runs the superior gluteal nerve. So make sure that excessive retraction should not be done superiorly. As far as concerned, the dissection you should consider as distally as possible. So on further dissection, you will encounter the capsule. Here the T-shaped capsulotomy was done. Here to dislocate the hip anteriorly, the limb is flexed at the hip and knee joint, abducted and externally rotated. Then the corkscrew, the head was removed. Then the neck cut was made. Here the neck cut was about 1 centimeter from the lesser trochanter. So after the acetabular preparation, here we are placing the retractor anteriorly and posteriorly. Sometimes teardrop retractor has been placed inferiorly to view the 360-degree view of the acetabulum. Sometimes you can use a shank seam and pin posteriorly in the acetabulum. So reaming initially to remove the acetabular cartilage. So reaming is directed more medially and posteriorly rather than towards the acetabular roof. So until the subchondral bleeding is seen, the reaming is complete. So you can see the transverse acetabular ligament inferiorly. So what is the cup placement? So for the better version, cup placement should be about 45 degree of abduction and 15 degree of anteversion. The excessive anteversion causes anterior dislocation. Excessive posterior tilt retroversion causes posterior dislocation. So to get the native acetabular version, you should keep the cup 45 degree of abduction. So here the cup should be parallel to the line joining the transverse acetabular ligament, just parallel. At the same time, the anterior portion of the cup should be aligned with the acetabulum. Sometimes the posterior superiorly there may be overhang. So sometimes to have the proper hold, you should maybe to put the posterior superior quadrant, which is the safest quadrant to put the screws. So this was a periodical cocktail injection. Routinely we follow here. Ropivacaine, ketorolac, dexamethasone, clonidine. Sometimes adrenaline can be used, but adrenaline causes some arrhythmic reaction, so we are avoiding here. So to get the neck cut after acetabular preparation, we are coming to the femoral stem preparation. Sometimes DOT type 3, we may need to cemented prosthesis. So here initial picture shows the uncemented brooch and rasp. The next second one shows the cemented brooch. So after preparation of the stem, here the make sure that version, the femoral anteversion should be 15 degree of anteversion, so that we make the lesser trochanter as a landmark. So after putting the final prosthesis of the femur, acetabulum on the head, the hip is mobile, flexion, extension, and minimal external rotation. So to prevent to look for the stability of the hip. So this was a hard hinge approach. So similarly, after reduction, stability was checked. Then finally, the closure was done meticulously. Initially from the capsule, then the anterior third of the gluteus medius was reattached back. So then the fascia, then the subcutaneous tissue. So this was a postoperative X-ray. So you can see the stem, the acetabular cup. So the postoperative care, the limb was kept in abduction pillow. Here, low molecular heparin was given initially for 1 week. Sometimes rivaroxaban can be given up to 35 days following the total hip replacement. So on day 1 post-op, the patient was allowed full weight bearing with the help of physiotherapist. So the complications is the complications. So in lateral direct hard hinge approach, you may have the abductor lurch because of the damage to the superior gluteal nerve, sometimes gluteus medius muscle. So make sure that care should be taken to prevent the gluteal nerve injury and the gluteal muscle damage. Sometimes in the early complication within 1 year, the mortality rate was 30% in total hip replacement. So dislocation is a major concern following hip replacement, especially in the posterior approach, as much as 3% chance of dislocation. So coming to the difference, total hip replacement provides a better functional outcome at the risk of more dislocations compared to hemiarthroplasty, which is a less operative time, less bed loss, but the more stable, but the revision rate was more. So here, however, the NICE guidelines 2023 shows that for active patient, cognitively intact, able to walk outdoor without stick, total hip replacement is a preferred treatment options. So most of the literature shows that functional outcome at 1 year after THR was better than hemiarthroplasty. So to prevent the chance of dislocation, nowadays modular dual mobility cups was used, which prevents the dislocation rate from 3% to 1.5%. So dual mobility cups, here there are two mobile junction, one between the femur head and the acetabular liner, and second between the acetabular liner and the acetabular shell. So which allows for the greater range of motion before the impingement occurs. Especially these dual mobility cups for instability, especially for revision cases, this was used. So another literature published in 2024, the yearly complications after total hip replacement was higher compared to hemiarthroplasty. There is a mortality rate and the chances of dislocation was more higher, especially in total hip replacements. So what I conclude, total hip replacement is a viable treatment option for patients having displaced intracapsular flexion neck of femur with a good and external functional outcome. However, the NICE guidelines 2023 says that it is more suitable for active, cognitively intact patients able to walk with or without stick outdoor. Thank you. Thank you, sir.
Thank you. Thank you, Kalai. That was an excellent literature review and presentation how to do a hip replacement through the padding approach. And yeah, before I hand over to Dr. Sanjeev Kumar, let me ask you 1 or 2 questions, because since arthroplasty is my field of interest also. So even Sandeep also, Deepak also, you can join in the discussion part. Even
Sure,
Raja
sir.
Bhaskara also, if you're around, you can just join in the discussion part. Could you stop sharing your screen? So
Yes, sir. Yes, sir.
so what is there any age criteria for doing a arthroplasty in fracture neck? That which age group you will do? Just give a cutoff mark other than the other factors.
Sir, as far as age is concerned, if the patient is physiologically active, able to mobile independently, so we may to consider osteosynthesis as the primary option. As far as undisplaced fracture is concerned, osteosynthesis should be considered as far as possible.
Now, let us
The
discuss
patient is
displaced
not.
fractures. Yeah, we understand, all of us, that undisplaced fracture, any age
Yes,
group
sir.
with the fixation is the treatment of the choice. We are considering 3 and 4, garden 3 and 4
Yes, sir.
only. Yeah.
More than 60 years, up to more than 60 to 65 years of age, if there is a displaced fracture, so replacement should be a treatment of choice.
Yeah. So usually in our practice, it is less than 60 years you try to fix it, whether it is displaced the fracture or not. And 60 to 75 is usually total hip, and more than 75 go for bipolar. What is your opinion, Dr. Sanjeev and Dr. Raja Bhaskar? Welcome, Dr. Raja Bhaskar. Thank you for joining. You are muted.
Sir, good evening, sir.
Yeah, good evening. Hi, good evening.
Yes,
Yeah, Dr. Sanjeev.
Sir, sir.
What is
I also wanted to discuss this point, that what should be the age when to call a patient elderly. And I totally agree with the Indian population that if you have age more than 65 years, and so if you talk about the cutoff age, so what the Sandhu et al. In his white paper published way back in 2005, they said that 65 and above, they may be considered as elderly in Indian subcontinent. But in worldwide, people usually consider more than 75 year age as a cut mark for osteosynthesis versus replacement. So this is what the difference in literature about Western and Indian population is. But yes, this is true that in Indian population, we consider any patient where physiological age is less than 65, where the patient is active enough to do all his activities outside his house, or if someone is a community ambulator, then he must be considered as active. So as far as age limit is concerned, my say is that up to 65 and beyond, we must think that we must go for a replacement sort of thing, and uh, below 65, we must think about this osteosynthesis sort of thing.
Yeah, and as Kalai rightly pointed out, two important points. One thing that, as you told you, is a community ambulator, and
Right.
number two, that it should cognitive function should be good.
Yes, yes.
That irrespective of the age. And third thing, I would add that, comorbidity, medical comorbidity. Many patients
Yes.
have got multiple comorbidities, medical comorbidities, especially cardiac issues. When they issue cardiac issues, it's better to go ahead with a quick procedure like bipolar rather than a totally arthroplasty.
Right.
Yeah.
Sir.
And next comes the approach.
Sure, very true.
Yeah.
Which one is better? Whether, I mean, most of us during our training time are exposed to the posterior approach, but at various centers in India, there, there are also direct lateral or modified Hardinge approach is being used by many surgeons. So, I think one should do the approach he is trained with, and there is no gross difference between these two approaches, for my opinion. And if you know, my teachers used to say you should use the approach by which you can do revision of your surgeries. If you can make expansion of your approaches in a primary approach, what you have done, then you should take that approach. For me, posterior is always better than the modified Hardinge approach.
Yeah.
What do you say, sir?
Deepak, what is your fracture neck femur? What approach you will do? You will go by your routine posterior approach?
Sir, I am trained as a posterior approach surgeon, but nowadays I am doing all direct anterior approach.
Direct anterior.
He's
So
a
it's
Indian guy.
preferable.
Super.
Yeah.
Be it bipolar or be it total, it's direct anterior for me now. All starting from. And second thing for me, yes, physiological age is more than of chronological age. And for me, not exactly 65. I think my patients are around 60, 60 and above and 60 and down. Because
that varies from person 60,
Yes,
65, it's fine.
60,
But
yes.
literature shows that anterior approach, direct anterior approach, and should be preferable in fracture neck femur. That leads to direct anterior is your anterior approach, anterolateral approach, less ensure dislocation. But I am a great follower of Dr. Ranawat, and I do everything by posterior approach, all primary revisions, and with posterior approach, with proper reconstruction of the capsular structures as well as the rotators, the chances of dislocation is much less, and it's comparable to anterior approach. So personally, I go by posterior approach, but literature supports direct anterior or anterolateral approach for fracture neck femur cases. Third important point is selection of the implant. Now, Dr. Kalai showed a cemented EP, isn't it? Both
Yes, sir. Yes,
cup
sir.
and he is cemented, but nowadays dual mobility is preferable. How often you do dual mobility? Sandeep, you do dual mobility for fracture neck femur?
Sir, fracture neck femur dual mobility, the choice if patient has got a hemiparesis. I always, I'm as like you said, I'm also a person posterior approach only.
Okay.
But then if dual mobility bipolar, the hemiparesis is the only reason when I consider.
Okay.
Yeah, for fracture neck.
Raja, you do dual mobility?
Yes, sir. So our indications for dual mobility are only if there is some neuromuscular involvement or in tumor excisions where there's a lot of soft tissue is removed. Otherwise, I think even young individuals, especially today, if we use even like a 36 head, I think a 36 head, I think the dislocation rates are almost minimal. I think a lot of other factors balancing also. Other thing is, I think you made a very good point, sir, about the cognitive function. So in cognitive function is poor, patient is very household ambulatory. In those kinds of patients, even a bipolar is actually better on the dislocation rate.
Yeah.
That, it actually allows them, it's much more tolerant to dislocation.
Yeah.
So I think, and one more statistic which I recently saw in the British Hip Society, we had a big consensus. About 73% of the world surgeons do posterior approach. 30% or 25% are still, only about 3% go the direct anterior as of now. It's picking up. But I think posterior approach is still the winner. But in our institution, except for the revision cases, we always do only hard insert. That's because the training has been there, sir.
Okay.
Where we've been trained for that.
Yeah, that's true. One important point which Raja told about size of the head. So in fracture neck femur, try to use as big head as possible. Dual mobility, we don't know what is the long-term outcome at present, but preferably dual mobility one can use. And if you are using dual mobility, it's preferable to use monoblock, cup rather than a modular cup. The literature shows the dislocation rate in dual mobility hip with similar size of cup. Suppose you take a 48 size of cup and use a large head, whatever possible, the 32 head, suppose 48 size, you use normally 32 size of head and use a dual mobility. The dislocation, compare the dislocation, it is similar dislocation there, provided your component position, everything is all right. Okay. But in smaller cups, less than 48, if you use dual mobility, the especially modular dual mobility, the polyethylene thickness is very thin. Okay. So it is 28 size hair, suppose you use 46, polyethylene thickness very thin. We don't know what is the outcome because polyethylene wear will be there on both the surfaces, both outer and inner surfaces. So there's a matter of concern using a modular dual mobility in smaller size of hips. Just Dr. Sandeep, if you can stop sharing your screen. Stop sharing. Your time has not come. I'll tell you when to stop share. When you share the screen, Dr. Sandeep, please stop sharing your screen. So that is the thing. So use as large head as possible, permissible by the system. That is the implant choice. The third thing next comes what about if you are doing anterolateral approach, anything in particular you are going to see, in your approach. I will tell you by posterior approach. Those who go with anterolateral approach, any particular thing you think, I'm talking about regarding limb length discrepancy. Anything, in our operating technique. Kalai, anything?
Sir. Sir, usually we check the center of the head to the trochanter distance by the trial and the final prosthesis. We restore the length. But with these two approach.
Raja, anything in your harding approach, anything specifically you look for while doing a fracture neck femur?
No, sir. I think all the
Standard
and routine stability. And you can be a little more reassured that the dislocation is little lesser than hard hinge approach. Compared to a posterior approach.
Dr. Sanjeev, anything specific in posterior approach?
I do a posterior approach.
Yeah.
We need to keep the version of the stubulum a bit more as compared to we do in a hard hinge approach. And the femur in a standard manner, I think so.
Just two things, two important structures. One thing, we many times we release the gluteus maximus attachment. Here you do not avoid releasing the G-max attachment because that may lead to lengthening. We release it to expose the acetabulum in a arthritic hip. But in fracture neck femur, you will easily, because soft tissues are lax, so you can easily expose the acetabulum. So avoid releasing G-max and avoid releasing the reflected head of rectus femoris, which is attached to the supraacetabular margin. These are the two structures which you usually release to expose the acetabulum properly to have vector exposure. But in fracture neck femur, since the tissues are lax, it's better we avoid. Otherwise, you usually land up in lengthening in these kind of cases. Anything else you want to tell, Dr. Sanjeev? Yeah.
Okay, sir. I am wondering whether if this is a valid question that whether to do a hemi or a total hip in an elderly patient. So what do you say?
Yeah, totally has got a better long-term outcome, and biomechanically it provides a better, function for the patient. So if usually expect the longevity of the patient is 5 years or so, then I prefer to do
Totally.
bipolar. But if the longevity is more, I prefer a total hip replacement because biomechanical better and patient's function is
Sir,
functional outcome is.
this longevity criteria of 5 years, is it literature proven or it's your own experience?
No, it was there in the literature that no, if the longevity is because bipolar is ultimately going to fail. It is not going to last for 15 years, 20 years,
No.
something like that. Which THR you can provide a 15, 20 years outcome. Because bipolar is
In
ultimately
fact, what I felt, it's very difficult to revise a bipolar for a neck femur rather than a THR for this. Yes, it is going on. If a bipolar fails and comes up, it's difficult for the elderly patients. So where I didn't know, I've gone through some lecture somewhere. I have listened. Now the criteria had changed to 2 years. The patient's longevity is going to be more than 2 years. Then preferred is THR. I don't know, but I have gone through some lectures and some conferences. Actually, I couldn't.
But
So I believe if
Yes.
someone is very active guy and who has a very active lifestyle,
Yeah.
then total hip is better than bipolar.
Yeah, definitely. So,
Yeah.
a tip to totally for garden over and these all things. But
Right.
this initially we are also taught like that. Now, if the patient longevity is going to be 5 years, so has it come down? That is the question.
And one more thing, sir, that
Yeah.
one thing about regarding cemented versus uncemented in elderly patient.
Yeah, good question. Yeah.
We need to also choose which type of implant this is.
Yeah.
So how to, I mean, we need to go with the femoral canal size, Ross classification, or by osteoporosis. How to, we must decide.
Yeah, Kalai, how do you decided to go ahead with the
Yes.
cemented one?
Sir, for type 3 door classification, the osteoporotic proximal femur, the canal is so wide, so better to avoid the periprosthetic fracture. Cementation is better rather than going for uncemented tight porous pit.
So
Yes, sir.
my sole criteria of selection cemented or uncemented is the bone quality.
Right.
Quality of the bone. If the quality of bone is good, it's a DOR type A, type 2, I prefer uncemented or, but type 3 or type C, then cemented. As Kalai told rightly, that cemented prosthesis scores over uncemented in periprosthetic fracture and thigh pain. There are two things cemented is preferable compared to uncemented.
Right.
So,
Yes, sir.
but having said that, if the patient has got, cardiac issues, high risk patient, cardiac issues, quick in, quick out procedure, then we prefer a uncemented procedure, provided the bone quality is, of course, has to be good.
Okay, sir.
Right, sir.
Yeah. Then just before we close this case, I request Dr. Sanjeev Kumar to summarize the points of the take-home message so that we go move on to the next.
Right, sir. So just to summarize this presentation and discussion, that in Indian population, more than 65 years, patient can be considered for replacement. Whether to hemi or total will depend on the activity level, activity status of the patient, and what approach you need to take. So the approach you do better, you should take. I believe the complications of both approaches, they are almost same. There is no one approach is better than another. So do what you know better. And depending on the bone quality, you must decide whether to go for uncemented or cemented. And also, the survival shape of total hip is better as compared to the bipolar in all these cases. So this is how we must decide with what to do in elderly patients.
Thank you. Thank you so
Great.
much, Dr.
Thank you,
Kalai
sir.
and Dr. Sanjeev Kumar for
Yes, sir.
being there. If you may continue just to take part in the discussion and the other cases.
Sure,
Yes.
Let me share the screen again to go ahead with the next presentation. So next presentation is related to sports medicine and arthroscopy, and we have Dr. Sandeep Lenka here to present the case. Dr. Lenka has finished his MBBS and MS Orthopedics from SCB Medical College, Cuttack, Odisha. He has finished his fellowship in knee and shoulder arthroscopy and at present working as associate professor in Institute of Medical Sciences and Shyam Hospital, Bhubaneswar. And to moderate this case, we have our very close friend, Dr. Sandeep Biraris, who is the head of the Orthopedic Department at Mumbai Port Trust Hospital, Mumbai Port Authority Hospital. Dr. Biraris is at present Secretary of Indian Arthroscopy Society and Treasurer of Maharashtra Orthopedic Association, and at present also Executive Committee member of the Indian Orthopedic Association from Maharashtra. He has been the past Executive Committee member of Bombay Orthopedic Society, Maharashtra Orthopedic Association, and has been very active, in arthroscopy as well as arthroscopy. Thank you, Dr. Sandeep, both, Dr. Sandeep Lenka and Dr. Sandeep Biraris for joining today. And may I welcome Dr. Sandeep Lenka to present his case.
Thank you, sir. Sir, am I audible?
Yeah, you are audible. Just
Yes,
share your screen.
Thank you, sir. So today I am going. I have shared, sir. Is it visible, sir?
No, not now. Can you stop sharing and share again? And recently also, Dr. Sandeep was organizing secretary of Odisha Arthroscopy Society conference, state conference, and it was a hugely successful conference.
Yeah.
You had shared in between, just in the middle.
Sandeep, again reshare it.
I have shared, sir.
No, reshare it again.
Stop sharing and again start sharing.
Now, sir, it has been shared.
No, not really. We are not able to see. Yeah, it's coming.
It's coming, sir. Is it okay, sir?
Yeah, now, but your presentation is not seen.
Yeah.
Presentation not seen.
New share.
Yeah. No, your screen was seen.
Yes. Okay.
First screen share, then you open your presentation.
Keep the presentation open in the background.
Share screen.
Yeah.
Yes, sir.
Yeah. Now you open your presentation.
Yes.
Yeah. Now
Yes,
make
sir.
it full screen. Make it full screen.
Sir.
Perfect.
Yeah. Perfect.
Is it okay, sir?
Yeah.
Okay.
Okay. Now
Thank you, everyone, for allowing the discussions regarding arthroscopy, sir, and very good evening to all of you. So today I am going to discuss a rare case, sir. In ACL reconstruction, we have faced a rare complications. So we know now the emerging thing in arthroscopy is all inside ACL and PCL reconstruction. And as we know, this technique was developed to improve the surgical outcomes. And the advantages are all inside ACL is less invasive surgery, decreased bleeding, faster recovery, and better tension control over the graft. But due to this half technique, we can allow quadruple semity and quadruple tendons. Though we are taking a single tendon, either it is a semity or peroneus, whatever, even if a small tendon can be made quadruple, and we can achieve the proper diameter. And with medium to long-term survival rate, ACL reconstruction with all inside technique is quite good. So in our case, it's a 50-year-old male which is having a history of injury of right knee since 1 month. Now he is complaining of pain and instability. Regarding the examination, his range of motion was 20 to 90 degree. Further flexion and extension was painful. His Latchman was grade 3. He was having joint line tenderness. McMurray was positive. And X-ray seems normal. And the MRI finding was there is complete ACL tear and there is bucket handle tear of the medial meniscus. So after proper investigations and the PSC, we have planned for arthroscopic ACL reconstruction, and we have done with all inside method. So this is the intra of arthroscopic view. There is presence of bucket handle tear of the medial meniscus. For this, we have repaired it, and this is the intra arthroscopic view of reconstructed ACL using hamstring autograft with all inside technique. So post-op it was uneventful, and after that we have planned for discharge. Before that we have done one post-op routine post-op X-ray, but unluckily in the routine X-ray we found that there is something suspicious. So we have done both epilateral and the oblique view, and in all the three views we found that the endobutton was near to the tibial plateau. It's not in its original position, because we have used fluoroscopy guidance during surgery, because we have faced few complications of flipping the endobutton in the soft tissues, not on the outer cortex, and mostly it occurs in femoral aspect. But here to rule out any complication, we have routinely checked it, and in intra finding both endobuttons over the femoral and the tibial side were placed in proper position. But in the post-op X-ray, we found that the tibial endobutton was near the joint line. It doesn't seem okay. So here the dilemma was what to do. So we have decided either we can proceed for redo of surgery with the same graft, or we have to harvest a completely new graft and redo the ACL reconstruction. So with the discussions of different colleagues, so we have planned for redo the surgery, and both options we have kept. Either we can proceed with the same graft, or we have to take another graft and proceed again. So this is the intra arthroscopic view. While examining, we found that the button is not over the tibial cortex, and it has entered but not inside the joint, so below the joint. And when I tried to push the graft entered completely inside the joint. So we plan to revise but with the same graft. So what we did, we made one transpatellar portal. So we have made anterolateral, anteromedial portal, and now we made one transpatellar portal and increase the incision of the donor side. So we tried our level best to keep the same graft, and what we did, we tried to pull the graft with the previous button through the transpatellar portal, and we tried to enter to make loop of 2 fiber tapes through the intact ACL over the tibial loop, keeping the previous endobutton intact, because the fiber about the endobutton helped us to pull the graft. So we passed 2 grafts, 2 fiber tapes, and then we fixed the tibial side with a larger button, not as conventional endobutton of 8 mm. We took button size of around 14 mm, and again doubly fixed or doubly sutured it with one tibial post. So this is the picture showing larger button over the tibial aspect, and we found the cortex over the tibial aspect was anyhow broken. It's not intact. So the fear of further migration, we fixed with another suture post, tibial post. And this is the, so post-op it was uneventful. Luckily we didn't face any infection, and we followed routine protocol. Weight bearing and physiotherapy was continued as advised. And this is the 4-month post-op. The patient, it's a X-ray, AP and lateral view with intact endo button of the femoral side and the button and a tibial post over the tibial side. The range of motion is now 0 to 120. The Lachman and the anterior drawer is grade 0, and there is no joint line tenderness. So this is the extension and the flexion view of the same patient at 4-month follow-up. And we have tried for anterior drawer, and we have tested for the Lachman, and it seems overall everything seems okay without any laxity and without any joint line tenderness. So this is the range of motion of the patient. It's from 0 to around 110, 120. So anyhow, it seems the ACL, reconstructed ACL has, the body has taken it properly, and there is no further laxity. So I saw different papers, but in lots of paper we found that the endo button problem was over the femoral aspect. Most common complication of all inside ACL reconstruction is button malposition or button maltracking in the femoral aspect. But in a rare, few rare cases of tibial button malposition was there. This is one paper in the Journal of Isacus. It was published in 2024 by Nicholas and co. Their paper showing, this is their paper of intra view in a pediatric age group. They have done all inside transfacial ACL. This is the intra view of C-arm images, and this is the immediate post-op view, which showed that they have faced the similar problem of tibial button migration towards the joint. So they again revised it, and during intra of arthroscopic finding, they found that the tibial button has migrated towards the joint. So again, they revised the surgery, and the follow-up was uneventful. So they have reported in the Greece Journal of Isocus. This is the first case of reported in literature with a tibial suspensory fixation device having intra-articular migration. So their paper was regarding the pediatric age group, but I didn't got any paper of adult migration of the button, or there may be paper which has not been published. So, so luckily we have managed the case with the same autograft. We don't have to harvest any further graft, and without any infection, the post-op was uneventful. Thank you. Thank you.
Thank you, Sandeep. That was an excellent presentation of the rare complications.
Yes, sir.
Sandeep, Biraris, how often you see your this complication?
No, so sir, this complication is reported in the literature, because as Dr. Lenka has clearly shown review of literature as well. So if the bone quality is not good, and when you tighten too much force, so that can weaken the tunnel, and that can lead to shifting of or migration of this button into the tunnel. That is possible. Now he has shown one case where in a pediatric population, so to avoid the physis, the surgeon has done deliberately that put that button into the physis only, so that to avoid the crossing the physis. So that was also a good idea. But if the bone quality is not good and tunnel placement is also not good, that can lead to migration. Now, in Dr. Lenka's case, I just wanted to know, So but Dave, you did all inside, right?
Yes, sir.
One sec. Sir, can
We have
share
checked.
the screen?
We have
Can,
checked.
can you
the
can you
TPL
stop
button.
sharing the screen, Sandeep?
Okay.
Yeah.
Yeah.
Okay.
Sir.
So in your case, it was your plan was all inside from day one as well,
Yes, sir. Yes,
right?
sir.
And the tunnel was little anterior.
The tunnel was anterior, but when we fixed the tibial endo button, the button was outside of the cortex. Means I have checked it. There is no cortical breakage, and we have not routinely, but in few times when there is a doubt of fixation of the endo button in the soft tissue in femoral aspect, sir. So we have checked it. CR view has been taken, but uh, unfortunately, after 2 days in routine post-op X-ray, we found that the button was near the joint. It's not at the routine place where it should be. Sir.
Correct. So so you revised it on the next day, right?
Yes, sir. Yes, sir. I've revised it.
So I just wanted to know. So how did you plan your revision? I mean, what exactly? So as you had shown very clearly that you removed the button and then you took another tunnel.
Yes, yes.
And
We found that the button was not over the tibial cortex. So also the button was not also inside the joint. Somehow the button has migrated from the cortex into the tibial tunnel, sir. So we tried to push the graft towards the joint, and the suspensory things which were over the button, we have made one transpatellar portal, sir. Through this portal, we tried to pull the graft, sir, because we,
correct.
yes, sir. And luckily, we found that we can reach up to the loop of the graft over the tibial side. So this is the first case for myself, and we tried to put fiber tape. And luckily, though we faced difficulty for 5, 10, 15 minutes, but luckily, finally, we were able to make a loop of 2 fiber tapes. So we thought we can go through the same graft. We don't have to harvest any further graft, because during drilling we have made the tibial, kept the tibial graft around, sir, 20, 15 to 20 mm. So I don't know whether the drilling, because during surgery, sir, my assistant has drilled the tibial tunnel. So at that time, no such cortical breakage was there.
Right.
But maybe
So
it may be possible, sir, during tightening of the femur.
yeah, that is
So,
possible.
though it is an adjustable loop, so
Correct.
finally we have tried from the femoral aspect to
Right.
the graft tort.
So you did
So it is.
revision, so all inside, right?
Yes, sir. Yes, sir.
Okay. So very well case.
Yes,
So it is from the X-ray only you suspected.
in the post-op X-rays, the graft, the endo button was towards the joint. So it should be within, sir, below 1 centimeter or 1.5 centimeter below the joint line. But we found it is near total towards the joint. So it was suspicious.
So Biraris, I'm just layman's question. Suppose we leave it like that. It has not gone to the joint, but it is maybe near somewhere in the joint.
But sir, yeah, so
Will
it's
it
a
cause
good
any
question, sir.
problem?
Correct. So it's very good question, sir, because what I'll tell you, in that case, over a period of time, once the patient is mobilized, then with the force of the ACL and during the rehabilitation, there is a chance that it may get pulled out into the joint. So that is a possibility. So it's a very good decision taken by Dr. Lenka, that like he executed what exactly anyone would have done in a better way. Actually, when we saw his first X-ray, which he has done immediately post-operative on the first index surgery, the endo button in the femoral side was also little away from the cortex. But when he revised it, now that endo button was also sitting right onto the cortex. And he also did one good thing, by doing a dual fixation. Because dual fixation, many people, they still follow dual fixation. That means the fixation with the suture disc. So even he replaced the suture disc or endo button with the suture disc. So that gives a big fixation. Then he put one suture post distal to it. So that also gives additional fixation. So that means stability is very well assured. So that was a very good decision which he has taken. And the revised X-ray looks beautifully well with excellent outcome.
Next question. Do you do it immediately next day, or you wait for some time? Ideally speaking, suppose you see this, then revise it immediately next day. Because if you do immediately during that time, there will be inflammation, soft tissues will be friable, as you find like any other surgery. Or you wait for, suppose, say 2 weeks or so, then do it as the inflammation settles down. What should be the ideal time to redo it?
Sir, question to me, right, sir?
Yeah.
Yes.
Because
So,
I
sir,
want to learn.
So, sir, if I do as everyone, we do the immediate postoperative X-ray next day or same day in the evening. And if I would have been in Dr. Lenka's place, if I would have noticed this, I would have revised it. I would have told the patient that such and such is there. It looks like there is a bone is little weak and the button is little proximal. So we'll do one thing, we'll do little adjustment. We'll take you in the operation theater tomorrow and we'll adjust and then we fix it up. Because what happens, sir, if we think of doing it after 2 weeks, then already the healing process would have started. And I don't think there is any harm if we are operating next day of the surgery. In fact, because he operated next day of the surgery, the recovery was very well like a normal surgery. But if we think of deciding revision after 2 weeks, then things would have become different, like maybe need for another graft. So now what Dr. Lenka could achieve by operating the next day is he could use the same graft. Only thing is that he took new tunnel and he added double fixation. So that fear of his mind was also gone and he could rehabilitate the patient faster. And that's the reason, like we saw, it is very excellent functional outcome. Because 2 weeks would have caused it more fibrosis and situation would have been little more challenging.
And he could sleep better also.
Yes.
Definitely.
That's a very important point, actually, which you pointed out. You should inform the patient first.
Yes, sir.
So any complications happens, first thing, you, the surgeon himself, should take the patient into confidence. That is, at present age, every patient is aware and, everywhere the X-ray moves around. And before somebody else informs the patient, let the surgeon himself inform the patient about complication and take it easy the patient's tension and do it as early as possible so that, you go ahead so that you have a good sleep. Okay.
Yep. And sir, if we do it immediately next day, soon enough, the acceptance from the family is very high because they will say, okay, no problem, doctor, please do what you think. But if you try and push it for 2 weeks and 3 weeks, they'll say, why you did not do it earlier?
Yeah. And then during the course of time, they may take a couple of other opinions, then they'll get confused.
Exactly.
So before that sets in, you should address the complications.
So I just want to share one same photograph. So I think Dr. Lenka will see this case.
Sir.
Can you see the screen?
Yes, sir.
Yeah.
Yeah. So sir, here also, sir, the patient was operated. The tunnel is, I think there is a very thin tunnel and which has blown out. And this cap, you see this T button, ideally it should have been somewhere here. If you can see my cursor.
Yeah.
So that is right, very much proximally. It's same like, so I had revised this patient after 3 months. Patient came to me after 3 months of the index surgery.
Okay.
Yeah. So when I did arthroscopically, button was completely inside the joint.
Suppose it has happened, seen in the X-ray. Do we need to do an MRI again, or it is not required?
No, sir. This was a different issue, sir. Patient was already treated and patient was undergoing rehabilitation. Patient was not happy. So this patient, when patient came to me, when I saw the patient had already done in life span of 4 months, 8 MRIs.
Okay. So before we close into the case, may I request Dr. Sandeep Biraris to summarize and give take-home points, a couple of 2-3 points.
Yes, sir. Sir, it was a very wonderful case which Dr. Lenka has shown, because many times the surgeons do get driven by the industry. They tend to use, what is been, some industry promotes. So Dr. Lenka has shown very well the all inside ACL reconstruction. Now many people are doing it with a very good sophisticated equipments. But what he has shown one a complication of this all inside, where the button has migrated into the joint. And good thing he did was, when he came to know about the same. So the take home point is, you should always do post-operative X-ray. So you know what you have done. So like doing arthroscopy, you think, are no need for post-operative X-ray? No, because many times you can see many wonders during the post-operative X-ray. You come to know what exactly is the problem. You know what exactly has happened. And if you notice your own patient, there is some problem, communicate with the patient, tell them this and this thing is there, and we are going to take care of it. Don't worry, it is not going to change your line of management. So whatever may be the little financial problem with the, like anesthesia and all those things, that is okay. But then they do accept, and you revise your own mistakes, you sleep peacefully, the rehabilitation is proper, and end result is good. So that's a very nice case you presented.
Thank you, sir.
So as it as justice to our concepts and controversies. So that's correct. It's a very good case, sir. Good case done.
And
Thank you,
also,
thank you.
and also the patient sleeps peacefully.
Yes,
The
sir.
patient is happy. Luckily, the patient is happy now, sir.
Thank you. Thank you, Sandeep, for an excellent case. I think you should consider it for publication as a case report that it has happened.
Correct.
And thank you, Dr. Sandeep Biraris, and both Sandeeps for your time, for discussing the case.
Thank you for the opportunity, sir.
Thank you.
Let's move on to our next case, and the third case will be related to orthopedic oncology. And to present that, we have Dr. Nandlal Bharwani. Dr. Nandlal, completed his bachelor's degree from Sardar Patel Medical College, Bikaner, Rajasthan, followed by his post-graduation from the Sampunananda Medical College, Jodhpur, Rajasthan. And at present, he is pursuing a fellowship in orthopedic oncology at Gujarat Cancer Research Institute, Ahmedabad, Gujarat, under the mentorship of Dr. Abhijit Salunke. And Dr. Nandlal has got more than 30 articles published in index journals in national and international journals to his credit, and has a book chapter on 3D printing in orthopedic oncology, and has got patents on scapular implant as well. Thank you, Dr. Nandlal, for joining today. And to moderate the case, we have Dr. Raja Bhaskar, who is Associate Consultant at Ganga Hospital, Coimbatore. Dr. Raja Bhaskar specializes in arthroplasty, ortho-oncology. Besides his plethora of fellowships which he has done, sarcoma fellowship from Royal National Orthopaedic Hospital from United Kingdom, clinical fellowship at Newfield Orthopedic Center from United Kingdom, Girdlestone Scholar in University of Oxford, and clinical fellowship in Oxford Bone and Soft Tissue Tumor Service. Dr. Raja Bhaskar has also got many awards in gold medals in his career. And I think due to lack of time, it will not be possible to enumerate everything. But thank you, Raja, for joining today.
Thank you, sir. Thank you, sir. Pleasure.
Now I'll stop sharing the screen and invite Dr. Nandlal to share his screen and present the case.
Good evening, sir. Thank you so much for the opportunity to present a case on OrthoTV. And I'm thankful to all the judges sitting here. I am presenting a case on distal femur tumor. This is a basic case in the orthopedic oncology that we encounter every day. This is a small video of the case presentation of a 13-year-old kid presented to us with complaint of pain and swelling since 2 months. In this, we can see a dilated veins and a shiny skin along with a biopsy scar. And as we can see, the range of movement is a bit restricted due to the pain and swelling of the patient. And the patient is not able to do a full flexion and extension. is not able to perform the active extension. And on the palpation, we are checking for the temperature and the tenderness. And on the tenderness, the patient has also winced. And on the palpation, we are doing the bony markings of the patella and the knee joint. This is the proximal part of the fibula. This we are marking as the tumor area. Along with this is the skin incision for the final surgery involving the biopsy scar mark. For doing the distal femur or proximal tibia, we are using the medial approaches. And this is the active range of motion. The patient is not able to do by himself. Then we have gone for the distal pulses, and we can see the atrophy distal to the tumor. This is a knee joint examination, and along with neurological examination and lymph node examination is there. Gait analysis we were not able to perform because the patient was not ambulatory. This is the radiograph of the patient that presented to us in the clinic, and this is the chest X-ray for the systemic examination. This is the full-length MRI of the patient involving the distal part of the femur. These are the axial views of the tumor extension. And for the systemic staging, we are using the bone scan and the CT thorax, followed by the biopsy. So, sir, this is a digital radiograph of a skeletally immature patient involving the distal part of a femur, having involvement of the epiphyseal-metaphyseal region along with a sun ray type of periosteal reaction with no cortical breach, and the lesion is extending into the soft tissue also. Then after we have gone for a CT scan of a patient to get a good idea of a cortical breach and periosteal reaction that was not visible on the X-ray clearly. That involves the medial part of the femur condyle. And then the patient was sent to the neoadjuvant chemotherapy after the diagnosis was confirmed as a distal femur osteosarcoma. These are the MRI images of the post chemotherapy when the patient was planned for the surgery. This is the systemic examination that I have told previously. We are doing as a CT thorax, abdomen, pelvis, and bone scan for the systemic workup. This is how we do a planning of the case just before the OT. In this slide, I am sharing the key surgical steps of distal femur megaprosthesis. Moving from left to right, these are the steps of distal femur megaprosthesis. In the second step, we have raised the flaps. Third one is we have marked for the femoral osteotomy site. Then in the left side, we are seeing the neurovascular bundle and the sciatic nerve along with a resected specimen. And on the right side of mine, there is a distal femur megaprosthesis trial, which we take just before the implantation. This is the final picture of the distal femur megaprosthesis. This is the distal femur rotating megaprosthesis. This is the post-op radiograph anterior posterior lateral view of the rotating distal femur endoprosthesis. Thank you so much for my case presentation.
Thank you, Nandlal, for presenting this excellent case. And do you have a follow-up of this case?
So follow-up, sir, I'm not having the follow-up radiograph, but the case has been done 6 months before back.
Okay.
Right now, I'm not having the post-op radiograph.
Okay. Can you stop sharing the screen? We'll have some discussion. It's a classical case of osteosarcoma fluorine of the femur and where megaprosthesis has been done. So let us go about, step by step. That Raja, you are there?
Yes, I'm here, sir. I'm here, sir.
Yeah. Just we'll discuss about, for the benefit of the postgraduates also, there are many postgraduates are also viewing this, case presentations. That how do you decide
sir.
that the limb is salvageable?
Yes, sir. So I think it's a very good presentation by Dr. Nandlal. So as sir said, I think first of all, olden days about till 1970s, we had osteosarcoma. The treatment was amputation. But
Right.
nowadays, today is the era of limb salvage. So more
Exactly.
than limb salvage, I think preoperatively you have to make the decision that it's a functional limb. So for example, in the pelvis hip, if you have to salvage, there is the hip joint, there is the femoral neurovascular bundle, sciatic neurovascular bundle. If any two are sacrificed, then no use keeping the limb because it's functionally it becomes not viable. Same thing in the distal femur. If the neurovascular bundle is completely involved, poorly taken biopsies involving the extensor mechanism in the rectus, it's a big biopsy, and also if you have to take out the entire specimen involving the entire musculature, which will be that is mainly the extensor mechanism. I think those are things which are not salvageable. So if the tumor infiltrates or invades the neurovascular bundle, and if it's in the extensor compartment in the distal femur, I think those are limbs which are not salvageable.
Excellent. So these are the very important points. Dr. Nandlal, you agree with this?
Yes, sir. Absolutely. I agree with the Raja sir's thoughts on the limb salvage.
Yeah.
The
Okay.
functionality of the limb is most important for the limb salvage surgeries.
And how do you see this neurovascular involvement? Which images, CT, MRI, which you should do to know the neurovascular involvement better?
So
It is.
yes.
Yeah, you can go on, Nandlal.
Yeah, Nandlal, you can go and Raja will correct anything.
Sir, just planning for the surgery, we will see for the axial sections and along with the CT angiogram of the affected limb, we will check. And if we are having any doubt about the involvement of the neurovascular bundle on the axial sections of the MRI, we go for the CT angiogram of the affected limb. And then after we will plan for the surgery. And if at all required a vascular graft, then we keep the vascular graft as a backup in the operating room also. Sir.
So for the postgraduates, the vessels are seen better in CT and the nerves are better seen in MRI. Am I correct, Raja?
So I think the MRI, especially the T1 weighted sequence, is a very good enough indicator for us to find out if the vessels and the neurovascular bundle is exactly involved. CT, especially, you will just want to see the mineralization and the amount of cortical involvement, sir. So frankly, even if you don't take a CT scan for the tumor, you're not losing out on anything. So doing an MRI, all the sequences, and some people give contrast also, you will be able to completely make sure. And the most important thing is tracing the entire neurovascular bundle. You have to trace it from up in different sections, especially in the axial, and see how much. So usually the radiologists say if there is a 180-degree coverage, 180-degree, if the tumor gets encased, then still you have to consider it as that the vessels are involved. If the tumor it's 180-degree over 3 different planes, but that depends from radiologist to radiologist. But I think, sir, MRI itself is a very good investigation, all sections, to find out if the neurovascular bundle is involved or not.
Okay. Next point is how long to excise? How do you decide on that?
Yes, sir. So nowadays, I think this limb salvage principles have now been varied very much, and nowadays the concept of margins is very important. So olden days, the rough calculation is if he's usually osteosarcoma, after doing the staging, we do chemotherapy, the neoadjuvant chemotherapy, about 2 to 3 cycles depending on the response. And MAP protocol is preferred for young people, but high dose, even the other IAP protocol also is followed. Now, how do we decide how much to resect? Now, the margin is actually, if you see the paper by Dr. Kawaguchi, exactly. So the joint comes to about 5 centimeter. So there are different things of how they have. So normally, if it's a poor responder, like you give chemotherapy, in other words, and the tumor is increasing in size, then you have to do at least 5 centimeter. Chemotherapy, good response, you can even do to 3 centimeter. So at least minimum of 2 centimeters. A soft tissue coverage, at least minimum of 2 centimeter bone resection. If it crosses the joint, then you need to do an extra-articular resection. Up to the joint, you can just do a joint sacrificing procedure. So for normal people, I think when we plan, minimum 2 centimeter resection of normal marrow bone, like in the MRI. And the other important thing is the pre-chemotherapy MRIs. What is, suppose it's 12 centimeter before chemotherapy and it comes to 11 centimeter after chemotherapy, we have to go with the pre-chemotherapy MRI. So 12 centimeter, so at least 14 to 14.5 centimeter, you have to take and then do the resection. Very good responders. Some people say, you know, you can even try being very heroic and you can go and salvage things. But I will say in the marrow, it's about 2 centimeter from the disease pre-chemotherapy level.
Good. So important points has been discussed. Also, MRI helps to see you how far the intramedullary extension of the tumor, isn't it?
Yes, sir. Yes,
That
sir.
also-
Intramedullary expansion.
Yeah.
Also, after chemotherapy, we see, and you know, the radiologists, some of them tell us the necrosis percentage, how much percentage is there. They can say, you know, it is good response, poor response, partial response, moderate response. They radiologists who are well versed with musculoskeletal, especially tumor imaging, they give you, and that also gives you another indicator, sir, of how to do the. And this one, I just wanted to ask Nandlal, is it a rotating hinge or which company is the implant you had used?
Sir,
Yeah, that's what I was.
Sir, it is a rotating hinge implant.
Yeah,
This
which
is-
company? Which manufacturer also? I just wanted to know.
Sir, XLO.
Okay, XLO, yes, yes. So
Okay.
that is another point for all postgraduates, or even I think it will be slightly higher for postgraduates, for especially for arthroplasty trainees and even for oncology trainees. See, in the long term, see, there are fixed hinges and rotating hinges. Fixed hinges, whatever said and done, it is bound to fail earlier because, you know, the fulcrum and the lever of the forces are very strict, and in especially young people, a maximum of 2.5 years, 2 years, it will fail. And there will be a breakage at the hinge. Rotating hinge is the one which you have to aim at because that gives at least, even in the Indian companies, the ones at least 7.5 years to 8 years, it gives you a very good amount of the average. Some people have about 15 years. So rotating hinge, the failure mechanisms are much more less. So, you know, always prefer a rotating hinge when you're doing an endoprosthesis.
So it's always we prefer. There is no indication for a fixed hinge.
So actually, there is one indication, sir. There is one indication is okay. It's like a partial indication. If you're doing a total femur replacement, sir, so total femur replacement. So what they do is you're having a dual mobility and also having a rotating hinge. Dual mobility in the hip and a rotating hinge makes it very, very unstable, sir. Quite unstable. So usually they say you put a routine conventional total hip in the hip and then put a rotating hinge, or you put a dual mobility and put a fixed hinge in the knee. So one area they want you to give a little bit more constraint. It is just a rough teaching, sir, but it's just.
Yeah,
but otherwise,
that's an important point also for discussion. That whenever you are doing total femur replacement, is preferable to do a fixed hinge. And we tell almost that whenever there is extension mechanism insufficiency, is preferable to use a rotating hinge rather than a fixed hinge.
Yes, sir. Yes, sir.
Just Nandlal, what is the neoadjuvant chemotherapy? What are the names of the drugs? Because you know they decide about dose and all.
Sir, in GCRI, we are using MAP protocol as Raja sir told. And, the first is high dose methotrexate and adriamycin and cisplatin. We are giving here for 3 to 4 cycles, sir, depending upon the response of the patients.
Okay.
And another thing is nowadays with the medico legal thing also coming for, especially you have to understand that if you are giving the IAP protocol, then you have to advise the patient for even doing sperm banking. So it's very, very important because they get azoospermic, whereas high dose methotrexate in the MAP protocol, you are covered by that. So it's very important nowadays, you know, these for all, even the orthopedic surgeons also to be aware that of the harmful effects or the side effects of chemotherapy with relation to their ovulation and reproduction if they become survivors in the long term, sir.
Okay. Next important point, intraoperatively, how do you assure the tumor clearance?
So,
Do you send intraoperative projection from the medullary canal after doing the resection, or you just send it and post-operatively you see?
so you are asking me or Rajas?
Yeah, whatever we
where
are discussing, we are all are discussing. I am asking as a layman because I don't do tumor surgery, but but in postgraduate exam, suppose a case comes, then we have to ask the candidates. You can answer,
Mostly,
Nandlal. Yeah,
so mostly we are not sending frozen for all the cases.
yeah.
And we usually send frozen when we are doing a biological autograft, like we are doing a ECRT or liquid nitrogen. In that cases, we are sending the frozen. And for doing a regular endoprosthesis, we are usually not sending the frozen for the proximal part.
Yeah.
What we used,
so
what
Yeah, Raja. Yeah.
we don't say is it very needed, but otherwise I think intraoperatively it's a lot of preoperative calculation and making sure that there is appropriate soft tissue cover which comes with that, sir. Because appropriate soft tissue cover and your preoperative planning, it should be very.
Okay. And in which case now in 2024, which cases will you consider for amputation?
Sir,
Nandlal,
yes, sir. Sir, in which
you can.
neurovascular bundle is involved and the tumor resectability, we will end up in a R plus resections. So in that cases, we go for the amputations generally. And when the patient generally lost to follow up after having a good response to chemo, in that cases, we will end up in the amputations only.
I mean, suppose there is a tumor which is fungating and the skin is involved. In those kind of cases, also you try to do a limb salvage prosthesis by excising the skin margins.
So generally we defer to do a limb salvage in that cases because it is considered to be a not a good case to do a prosthesis in the longer run also. And these patients are more prone to a systemic disease because they came to us at the later stages, and most of the patients have some of the lung mets or some of the bony mets. So it is better to do amputation in comparison to limb salvage for the fungating tumors.
And after amputation, also you continue with chemotherapy?
Yes, sir. We send the patient to for the adjuvant or the palliative, depending upon the extent of the disease, sir.
Okay. And post-operatively, what chemotherapy do you give?
So same protocol we are
Same
following.
map, same map.
Yes, sir.
Okay. Raja, now up to you. Whatever discussion you can generate.
I
Anything
think it
else
was
you
a
would
very
like
good
to?
case and discussion, sir. But just for all postgraduates, the most important. So I just osteosarcoma over the entire years, sir. In 1970 still now, if you do non-metastatic at presentation, you do all the chemotherapy, get tumor resection margins free. Still, the 5-year survival rate is around 65%, sir. So even today, with all the advanced medicines, latest regimens, surgical techniques, all whatever happens, 35% of the children patients they die due to disease. That is the virulence and biology of the disease, sir. That has not changed much. So I think the chemotherapy regimens, there are still a lot of research going, and the factors which affect are the after we do the resection, we check the margins. So margins have to be negative. Margin negativity, and the other one is the necrosis factor. How much necrosis to chemotherapy? More than 90% is good. 90 to 95%. Less than that, that means the outcomes, the chances of chest metastasis and local recurrence also are slightly more. So margins and tumor necrosis to chemotherapy, those are very important factors which nowadays determine the prognosis.
Thank you. Thank you, Raja. Thank you, Nandlal. I think we have
Thank you, sir.
almost 20 minutes ahead of our time. Thank you for that excellent case. And really, I enjoyed the discussion because I clarified many of my doubts also, though I don't treat tumors. But there are so many things which that enlighten us today in 2024. What is the treatment?
Thank you, sir.
So,
Thank you so
dear,
much, sir.
Thank you, sir. Thank you so much, sir.
thank you, dear friends. So we had an excellent, session today involving arthroplasty, arthroscopy, and orthopedic oncology. And we thank all the speakers, Dr. Kalai, Dr. Sandeep, and Dr. Nandlal for presenting the cases. And we thank all our moderators also involving the arthroplasty doctors, Sanjeev Kumar, Dr. Sandeep Biraris, and Dr. Raja Bhaskaran. And we thank also OrthoTV. We thank Dr. Neeraj Bijlani and Dr. Ashok Shyam and Bharwani for being present here to manage the session. And before I close upon, I hand over to Dr. Deepak Gautam to give the concluding remarks.
Thank you all. It was a nice evening with all the new knowledge, new thing, starting from neck femur to arthroscopy to tumor. Thank you all speakers. Thank you expert panel members. It was a nice evening. We'll be back again with we are towards the end of the season 2 this year, and we'll be back with a new theme. And we're planning for upgrading this controversies and consensus session in the upcoming sessions. Thank you all. Have a good evening.
Good night and have a
Thank
nice
you,
evening.
thank you, thank you,
Thank you so much.
Bye.
Thank you, sir.
Bye.
thank you.
Bye, sir.
You can stop
You
streaming.
can stop live.
Maharishi, you are there?
Maharishi?
Hello.